I'd like to bring into our discussion Karen Voin, who, as I mentioned, is Vice President of Group Benefits at the Canadian Life and Health Insurance Association, so you can join our discussion. Brian had mentioned a little bit about the regulatory environment with biosimilars in Canada. Do you see any challenges that persist with respect to how our federal and provincial agencies track and manage biosimilar use?
Yeah, I do see there are some challenges still that we need to overcome over time. But I also see that there are some opportunities that, so we are making some headway in terms of moving things forward. So in terms of the challenges, PMPRB issued a report in the last year around biosimilar uptake in Canada. And one of the things that they identified in the report is that while there are cost savings associated with biosimilars, which we certainly see as an opportunity from a private payer perspective, we still, as a country, pay more than any other OECD country for biosimilars. And so there is some opportunity to continue to, expand on the cost savings related to biosimilars in Canada. And on the opportunity side of that, there are some reforms Health Canada has identified over the last couple of years that we do pay too much in general for drugs in Canada, and has started a series of reforms that would ultimately reform the PMPRB and modernize the PMPRB guidelines. And so, with that would impact the cost of presumably biosimilars as well and reduce that cost in Canada. So, there are some challenges, but there are also some opportunities. On the HTA side of things with CADTH, we've seen in the last 6 months, back in February, that CADTH has also gone out at the end of 2017 and done a public consultation, and then revised their processes in February of this year that are intended to really speed up the review process for biosimilars in Canada. I've seen it suggested that it would, cut it in half in terms of review time in Canada, which would be speed to market. So those are all, what I said, I started off by saying there are some challenges, but there are also some opportunities. And so I think we are, starting to overcome some of those. And I think really the opportunity here is, all of the system as a whole needs to align in order to really see the uptake for biosimilars in Canada. And the other challenge that I would say, and you touched on it earlier, Dr. Feagan, was around interchangeability and switching. So I think those are two other things that we still need to tackle over time to really see the uptake occurring here.
Yeah, because I think clinicians often worry that some of these concerns aren't really given due consideration by regulatory authorities. From what you're saying, do you think there is a pathway for some of these clinical concerns to weigh into decisions by regulatory bodies?
I do see glimmers of hope there. Yeah, I do see that a pathway is being formed. If I go back to a year ago and even look at it from a private payer perspective, it was interesting, and I'll pick up on one of the comments that Dr. Feagan made earlier, which is interesting for me because, we have a role to play in this as private payers in terms of uptake. And admittedly, even though we identified the importance of biosimilars back in a policy paper that we issued in 2013, uptake has been very slow, and I'll openly admit to that from a private payer perspective. And as Dr. Feagan alluded to earlier, there's multiple reasons for that. One of them is around, as you identified, that on the originator side, there are probably, with some insurers, some existing arrangements in place that were in place prior to a biosimilar being available in the marketplace in Canada, and so it needs to play itself out in some cases and may limit opportunities if an insurer has one of those arrangements. There are very few biosimilars available here in Canada, as we know currently. So over time, I think we're seeing some change, and insurers are now we're seeing insurers starting to introduce products that really encourage biosimilar uptake. So, there is a change happening. I'm seeing it over the last year and a half.
Biosimilars, due to the patent protection, are always 15 to 20 years behind new drugs. And in IBD right now, we're at a very interesting situation, both in ulcerative colitis and Crohn's disease, where our first generation biosimilars, in my opinion, are no longer first-line therapies. So essentially, depending upon, you can imagine, depending on the quality, and again, interacting with the U.S. environment, this is very clear. What type of insurance you have dictate what quality of drug therapy you get. And so Canadians, I mean, right now, we're in a fortunate position right now in Ontario, I think, but I think things will change, in that the gap between new innovative molecules being the preferred choice by prescribers and biosimilars being the preferred choice by payers is going to widen.
Maybe I can pick up on that point from Brian, because we all are, I think, keen to see cost savings in the healthcare system. We recognize that some of the growths in expenditure can't continue at infinitum, and biosimilars are certainly an opportunity to achieve cost savings. I think you've alluded to this already. It's important to the employers who purchase these plans that costs are contained. I guess from the flip side, as clinicians, how can we have some confidence that the savings that we see are in a way reinvested in some of the innovative therapies that Brian's alluded to? Is there a pathway to see that savings from biosimilars actually enhance access to some of the newer therapies?
It's a good question, and I would say in terms of cost savings, it's very early days, right? I mean, the cost savings today are really and would be driven by both uptake and availability of the biosimilar in Canada. And as we've discussed earlier, there's very little in terms of biosimilar availability currently here in Canada, but the pipeline is there, and the expectation is that there'll be many more biosimilars available over time, right? And uptake, we've also, talked about being very low at this point. So cost savings at this point for a private plan would be, limited at best because of the limited uptake.
I should say that we don't have a representative of the public payer system with us today, and I hope that in the future discussions we'll be able to bring in a perspective from the public payer, although I think there's probably a lot of similarity between private and public payer perspectives on many of these issues. So I think we can summarize some of the discussion we've had on this topic. Again, this builds on our previous roundtable discussions with CARE. We've, I think, summarized from the past where we've seen with biosimilars and some of the early and pivotal data from the Northwich and another Crohn's disease trial. We've discussed that we haven't seen a lot of new information over the last year, at least in terms of really groundbreaking data, but there's been an accumulation of observational experience from a number of jurisdictions around the introduction of biosimilars, and in some settings moving back to the innovator biologic in large cohorts of patients. And I think all of those data have been reassuring. There hasn't been a signal, but I think Dr. Feagan did identify there's still some knowledge gaps, and in particular this question of multiple switches between innovator and biosimilars, and of course going forward among various biosimilars with respect to durability of clinical response and also sensitization. And I think we've had some excellent input from the private payer perspective on some of the considerations that go into their decisions about listing innovator and biosimilar products, and some of the challenges also seen, I think, in the private system, and I think these align also with challenges in the public system with the uptake of biosimilars in the Canadian marketplace. So I think we're going to have a lot of future discussion on this issue. I don't think we've resolved all these questions, and hope we can reconvene again to continue our discussion.